Good evening, family and friends, and I welcome you to this month's rendition of the Omega Psi Phi Fraternity Second District Health and Wellness webinar. We like to talk about prevention and have conversation about how it relates to our people. So, and to that end, we have a very, very special program for you tonight. I hope you will certainly enjoy it because we have some interesting things we need to talk about tonight. As you know, this is colorectal cancer month, kidney cancer month, and multiple myeloma awareness month. But we've chosen to concentrate tonight on colon cancer and its different aspects of it. And so the information presented tonight and the discussion and topics presented tonight and opinions are those of the individual brothers and or presenters and do not represent the opinions of the Omega Psi Phi Fraternity Incorporated. So again, our purpose is to talk about prevention and how to deal with issues in our web space, in our space, and in our community. But before we get started, I'd like to take this opportunity to welcome our brothers and have them give their opening remarks. Now, our chairman, Dr. Jedan Phillips, may or may not be able to be with us tonight as he has some other obligations, but he's going to try to log on if he can. But nonetheless, we're still going to take this to the highest level. So with that aspect, I want to go ahead and ask Dr. Isabell if you will come on and give us your opening remarks, please.
Good evening. Once again, Dr. Lee Isabell, board certified internal medicine, also HIV primary care. My perspective regarding colon cancer screening, it probably has affected every one family member or everyone knows somebody who probably had colon cancer. Thank you to be here.
Thank you, Dr. Isabell. Is Dr. Plummer here? Did Dr. Plummer make it on? Okay, we'll go ahead with Dr. Ford. Would you give us your opening remarks, please?
Good evening, and thanks again for having me. Obviously, this is a very important topic, colon cancer. And hopefully tonight you'll be able to get a lot of great information on when you should get screened, and hopefully we can prevent a lot more colon cancers. Thank you.
All right. Okay, so thank you very much. So I'm going to reintroduce myself to some of you and reacquaint others with you. Again, my name is Dr. Keith Boykin, and I have over 30 years of experience in medicine. I have completed residency in pediatrics and internal medicine, and for the last 30 years before I retired, I practiced just pediatrics. So my take tonight is going to be as your moderator, and also whatever aspects we can talk about that affects other family members, particularly in the whole family unit. But tonight we have a very special guest, and someone who I think you will enjoy, and we have a lot of information we can get from this speaker. So without further ado, I'm going to go ahead and introduce him, and then I'm going to have him come on and give some opening remarks as well. Our guest tonight is Dr. Kester I.H. Cross, MD. He was born in Wilmington, Delaware in 1970 and is a distinguished gastroenterologist and healthcare leader. He earned his Bachelor of Science degree in biology from Hampton University in 1992, my alma mater, and his Doctor of Medicine degree from the University of Maryland School of Medicine in 1997. Dr. Cross completed his medical residency in internal medicine and specialized in gastroenterology at the University of Maryland Medical Center, where he became one of the first 2 African Americans to complete such a training. He's board certified in internal medicine and gastroenterology. He embarked on a career dedicated to patient care and community advancement. He joined Digestive Disease Association in Columbia and Baltimore, Maryland in 2003. He became the first African-American partner in the practice. Very, very significant. His commitment to excellence led to his election as president and chairman of the board in 2015, overseeing a team of 18 doctors and 103 employees. Wow. In 2021, Dr. Cross facilitated the merger of Digestive Disease Association with GastroHealth, a national platform boasting over 300 gastroenterologists across 7 states. He assumed the role of Vice President of Clinical Affairs for the Maryland Division, leveraging his expertise to enhance patient care and operational efficiency. Outside of his professional endeavors, Dr. Cross is an active member of the American Gastroenterological Association and a member of Kappa Alpha Psi Fraternity since 1993. Committed to nurturing future generations, he serves as a mentor and supports educational initiatives. Dr. Cross established the Charlie Lamont Howard Scholarship at Hampton University and the Cross Doctor Scholarship in Baltimore, enabling young individuals to pursue higher education, particularly in the field of medicine. Emeritus Dr. Keisha Cross, also a Hampton University alumna, University School of Maryland alumna. Dr. Cross is a proud father of 3 children. His eldest daughter, a graduate of Spelman College, is currently pursuing mechanical engineering at USC. He also has 2 sons, aged 18 and 16, both excelling in high school. Dr. Cross' dedication to his family, profession, and community exemplifies his commitment to excellence and service. So without further ado, Dr. Cross, give us some opening remarks, please.
Amen. Amen. Thank you for that introduction, Brother Boykin. It is, can everybody hear me? Is that coming through fine? Excellent. So
We can hear you.
I would like to start out by thanking God or whatever higher power we believe in that brings in the best of us, and thank the members of Omega Psi Phi, the founders, Pastor Love, who is responsible for my family, the Cross family, coming to America. My grandfather was a Methodist minister in the West Indies and applied for a job in Ethiopia and in America, and interviewed with Pastor Edgar Love, and they formed a bond, and we came to America. He had 3 sons that Pastor Love told about Omega Psi Phi, and they since joined the organization. So I have a fond memory of the purple and gold. As you might imagine, going Kappa caused a major rift in the family for about a year to 2. My father and I are on speaking terms, but you might imagine that might have been a big problem there. And then lastly, the members of the Health and Wellness Committee here putting this together. This is an amazing forum and something that's very, very important, because us as leaders, kings, men of our villages and homes need to be healthy. A strong king is a needed king, and that's why we're coming together. And then lastly, Dr. Jedan Phillips, him and I met in medical school, and for those of you that know him very well, he is such a great, transparent, strong man, and was a year ahead of me, but it was really a pleasure to meet a man that was like me, understood the struggle, and we faced that adversity, and we only got better together there. So today we will talk about colon cancer. We'll talk about things that affect us as a community, and really just have a transparent conversation, brother to brother, as many of you are, often in rooms where you're 1 or 2 Black men or Black people in the room. It warms my heart to be in a room full of people that look like me, and I can help everyone at this time. Can you share my slides?
All right, there we go.
Okay, and so I'll just say next slide whenever we go to the next. The title of the talk is the 10 Health Commandments, but the next slide, the goal, go back one, is basically to share the common diseases that kill us, certainly give you strong recommendations to lower your risk of death. I really, really want to motivate each and every one of you to maintain or to improve your health. The healthier you are, the stronger you are. Healthy is the new wealthy. Motivate all of us to get colon cancer screening. Certainly touch on prostate screening since it's an issue in the African-American community. My bullet point at the bottom of this slide is very, very important. I just it would be a whole lecture, and I have to point out the pre-existing American condition of discrimination and poverty cannot be understated. Poverty from discrimination cannot be understated, affecting outcomes in healthcare, because sometimes that gets missed when our counterparts talk about healthcare disparities, Black this, white this, and they do not touch on the fact that discrimination resulting in poverty is the overwhelming 40 to 50% of the effects of these disparities in healthcare. Next slide. So so limitations, talking about race, very important. You guys are all smart gentlemen. Is race related to genetics? Is it social, or is it cultural? One of our American leaders, Denzel Washington, gave a nice lecture that I heard saying that basically race in America is more of a cultural thing. It's how you're raised and the parts that come with that, and less skin color. The data collection is sometimes limited for the data based on who and what they see. If they think you're white, they may treat you like you're white, and they may record you as white. If they think you're black, they write you down as black. And sometimes you get to identify yourself, or you put down no answer on your data. But these informations are called, but there are limitations because it's either the person that's filling out the form or the person that's checking you in. And very, very important, the last part lets you know that implicit bias, which is the bias that people make assumptions by looking at you, really often guides your healthcare treatment. So any stereotypes that they have, good or bad, often determines how someone treats you and affects your medical outcomes, and that cannot be understated. Next slide. So not too busy slide, but looking at the overall death rates, this should not come as a surprise, but the main purpose of this study, of this test, is just to show that African Americans have the highest death rate of all American subgroups. The next one, Caucasians. Next is Hispanics, which Hispanics come with asterisks because they sometimes are underrepresented. Anthony Garcia may be checked off as Caucasian, and really he is a Cuban American. Asian Americans have the lowest death rate in America. So African Americans have the highest death rate per 100,000, and Asians have the lowest death rate. Next slide. Now, this slide is somewhat busy, but it wants to point out and highlight the top 10 causes of death, because if we target them, it rolls into my 10 commandments on how we lower our death rate. But the number one cause of death for people that look like us is going to be heart disease. That's cardiovascular death, 27%. Cancer is 22%, lung, prostate, colon, breast being the big four. And then third are going to be accidents, car accidents, drowning. We are well aware of the increase of accidental deaths with fentanyl for drug overdose, which was increasing in the suburban population and also in the African-American population, but it became a big deal 2012 on, and we heard a lot about it. But as you see, it's number 3 on the list. Stroke, 5%, diabetes, 5%, kidney disease, 3%, liver disease, 2%, lung disease, 2%, homicide, 2%, HIV/AIDS. I just have those last two on there because these two are not on any other American subgroups top 10. Homicide, many lectures are on that. But however, we know the pressures from discrimination and poverty leads to homicide. And HIV/AIDS is just more prevalent in African Americans. We're seeing a rise in heterosexual women, typically often not knowing that they're sleeping with bisexual men. So that is on the rise. And we have a lot of closeted sexual history. Therefore, HIV/AIDS is diagnosed down the road, and we see how that plays in with colon cancer down the road. But if you focus on the big 3, if you look at heart disease, cancer, and stroke, you're greater than 50% of the causes of death. So if we impact or lower these things, we can have a dramatic decrease in our causes of death. Next slide. So weight BMI, which is our size, is a major factor in mortality. It increases our risk of heart disease, diabetes, stroke, liver disease. As many of you know, African Americans are the heaviest American subgroup. Asian Americans are the lightest subgroup. Asians have the highest life expectancy. African Americans have the lowest life expectancy. What goes into weight, whether it's genetics, eating patterns, stress, all these things go into our weight and size. But the smaller we are, the more likely we are not to suffer a cardiovascular event. So Asians lead America, and Americans as overall are heavy, but African Americans are the heaviest subgroup. Next slide. So this leads me into my commandments, and I will spend more time on prostate cancer and certainly on colon cancer. But the first one, thou shalt not smoke. Why is that the first one? Well, clearly it lowers our risk of heart disease, lung cancer, COPD, flu, and stroke. Almost always there is a brother that will ask later on, can I smoke my cigars? And of course, the answer is yes, if it's infrequent. But some people smoke cigars on a regular basis, and smoking on a regular basis is not healthy. Intermittently, no smoking, puffing to be cool, not a big deal. However, smoking regularly, inhaling those toxins are a risk factor. So thou shalt not smoke. The next commandment is thou shalt control his weight. Pretty obvious from the previous slide. Why is that? It lowers your risk of heart disease, stroke, diabetes, cancer outcomes are better the smaller you are. So these are all obvious reasons to be as small and as healthy as possible. Thou shalt control his blood pressure and cholesterol, lower your risk of heart disease, stroke, kidney disease. Thou shalt control his diabetes. Well, hemoglobin A1Cs we like to regulate mainly because it lowers our risk of heart disease, stroke, kidney disease, flu survival. All of these are on the top 10 causes of death. And then lastly on this slide, it says thou shalt get a colonoscopy, PSA for prostate screening, mammography for your wife, loved ones, or sisters for breast cancer because it dramatically lowers your risk for colon cancer. We're going to touch on screening for breast cancer for prostate cancer, which in short, although controversial, I recommend most of you brothers get PSAs. And then certainly mammography has done a fantastic job of lowering death rates for breast cancer. Even though breast cancer is very common, 1 in 8 women get breast cancer. Women are more likely to die from colon cancer than they are to die from breast cancer. Next slide. My last 5 for my commandments. Thou shalt get the flu and COVID vaccine. Not really debatable about the facts, the opinions on why we should or should not get it and the motivations behind them are a whole nother lecture. But the regular flu kills about 50,000 Americans per year. And we saw with the COVID-19 pandemic, it killed 1,000,001 Americans and 200,000 were African Americans. So that's a 4-fold increase just in the African American population in comparison to what the common flu killed, and the COVID vaccine lowers our risk for that. Thou shalt wear his seatbelt, kind of self-explanatory because of car accidents. Most of the time we die in car accidents within 5 miles of our house because that's our road most traveled. Thou shalt wear condoms, if not monogamous. That's not for this group. It's typically more like Kappas or non-Omegas that have problems with the flesh. And I know you guys all are well controlled with the flesh and are monogamous, but for those that are not, it lowers your risk of HIV, AIDS, if you're not monogamous, to use condoms. Alcohol. Why is alcohol important? Well, it lowers your risk of liver disease, cirrhosis, and then the homicide risk is there. Many of you may know or may not know that half of homicide victims, either the shooter or the victim, have ingested alcohol at the time of the murder. So making sure we control our alcohol because it helps our impulse, helps what we say or not say, can limit our death rate from homicide. And then lastly, which is very important, the last commandment is manage stress management, health, wellness. Very, very important topic. It's getting talked about more and more, but it lowers your weight and fat formation. The higher stress, the more cortisol you have in the body, the more likely when you overeat, you gain weight. Stress increases our blood pressure, increases our heart disease, and certainly stressful situations increase homicide risk. And one important fact that I want to share with you is the most deadliest time of the week is Monday morning. And what is that significance about Monday morning? It's just that is the most stressful time for a man to wake up, think about his entire week. And sometimes that stress is too much. It leads to a spasm in the heart and they have a heart attack. Next slide. So with that, I'll just transition for the next 5 minutes to talk about prostate cancer and colon cancer, and then we'll handle any questions because I think the true power is in the conversation piece of the fireside chat with us amongst brothers. But I do want to spend some time on prostate cancer. It's a leading cause of death. However, screening is controversial. One main reason screening is controversial is prostate cancer death is not a major cause of death for the majority Americans. It is a major cause of death for African Americans. We make up 12 to 15% of the population. Local prostate cancer has 0 symptoms. I repeat, local prostate cancer has 0 symptoms. What are some symptoms of advanced prostate cancer? Where it can be bone pain, weight loss, difficulty peeing, which can be from a larger prostate, not necessarily unique to prostate cancer, but these are symptoms of more advanced disease. And then lastly, focusing on what is the survival rate? Well, if prostate cancer has made it to distal organs outside of the prostate, the 5-year chance of being alive is 30%, but early detection only in the prostate. Sometimes you hear these Gleason scores, etc. But basically, you would want to ask the doctor, hey, is it aggressive or not? Is it within the prostate? Those 2 questions let you know. But if it's within the prostate, the cure rate is 100%. Next slide. So how do we get screened? Everybody has heard about PSA, prostate-specific antigen. You're looking for levels below 4. You should get it yearly or every 2 years. It's considered a soft recommendation, mainly because of the impact for everyone. The impact for everyone makes these task force makes decisions, but for the people on this call, the impact is going to be larger than it is for everyone. And I hope that makes sense. So having screening does decrease your risk of death from prostate cancer. The risk reduction overall is small in comparison to colon cancer. That main reason is that colon cancer takes 20 years. Prostate cancer can take up to 20 years to kill you. If you are 60 years old diagnosed and you pass away at 80, well, because your average lifespan is considered 75 for an African-American man, there's no years of life saved there. So that does not count as years of life saved. So that makes for these calculations for the risk reduction to be small. What are the risk factors for prostate cancer? Where being African-American, you have a higher risk for it. If you have a family history of people diagnosed under the age of 65, you're at a higher risk for getting prostate cancer. So family history, or if you're African-American, you're considered higher risk, so certainly consider getting a screening. The task force, well, they say discuss it with the patient, screening versus no screening. The main thing that they hang their hat on is about the risk reduction being small. I have a line brother that was 45, diagnosed with colon cancer. Of course, I'm 54. He's still around. He's here. We talked about it. I recommended him getting screened. He had the surgery. He did fine. My grandfather died from prostate cancer, but I remember attending his doctor meeting when he was 72, saying that he didn't need to have surgery because he was going to die from something else. They were incorrect. He died at 92 from prostate cancer. But it took a long time, and 90-year-old funerals aren't as sad as the 60 and the 70-year-old funerals, which we're trying to prevent with this discussion today. Next slide. So my last couple slides are dealing with our major topic of colon cancer. Ironically, if you read the New York Times had an article about colon cancer today about how the death rates are increasing in young people, and it's anticipated to be the #1 cancer cause of death in the future. And we just had this discussion scheduled. But colon cancer disparities, well, 153,000 people are diagnosed per year, 52,000 deaths annually. That's down 55,000 pre-COVID. We anticipate colon cancer deaths to go up a little bit post-COVID because COVID screening rates were down. But historically, screening rates, as they increase, death rates have been going down. And all of disparities that we see with colon cancer are mainly related to socioeconomic status and the differences with access to screening, early detection, and treatment. And I just want to say that again, socioeconomic status is the main difference. Access to screening, early detection, and treatment. If it's detected early, outcomes are the same. So my last point on this slide, you'll see when it's diagnosed early, colon cancer death rates are similar amongst all racial groups. All racial groups is the same. If you catch it early, but catching it late is our biggest problem as African-American men. We either don't get screened or we come in with symptoms. And if we have symptoms, the cure rate drops down to about 50 to 60% from the high rate of 90%. But it's very, very important for us to know, because we get a bad thing of what does it mean to be African-American? I'm going to die from this, I'm going to die from that. You do not necessarily have to die from colon cancer if you get screened. And those that have access to healthcare should be screened. Next slide. So these facts are all coming out. We are heard about them. We hear them. They're true. African Americans are 20% more likely to be diagnosed with colon cancer, and we're 40% more likely to die from colon cancer. And the main reason are what I mentioned earlier. We present later in life. A single Black man is my personal most difficult patient to get screened. That's my least likely group to be screened. A single Black man often has other barriers as it relates to not coming to the doctor. And married men go, their wives nag them often, or you scope their wife and then they bring their, the husband comes in and says, hey, it's not so bad, I'll get screened. So married Black men live longer than single men. That's a word or a preacher to somebody on this call. Married Black men live longer than single Black men. And I joke at work that it's just because their wives make them go to the doctor and get well visits or screening visits. And single Black men go to the doctor when they feel bad. And if you go to the doctor only when you feel bad, your likelihood of survival is going to go down, because we need to find stuff early with those screening tests. And why don't Black men go to the doctor? Well, often Black men don't have good encounters with the healthcare system at an early age. We get turned off by the healthcare system, but also after high school, we're told and instructed to go to the clinic when you don't feel well, when you're in college. If you have a cold, you have a flu, you're not feeling well, you break your arm, you go to the doctor. So if there's a problem, you go to the doctor. And when you compare that to our female counterparts who have to get GYN visits, they have to have well visits. If they find a doctor that they don't like, they just ask their girlfriend, they find another doctor. They have to find a physician that they like and work with, so they're more likely to stay in the systems in their 20s and 30s. So once they turn 40 and they're told, go get a mammogram, go get a colonoscopy, get this blood work done, they go off and get it. We have not been in the healthcare system, and the system wasn't nice to us. 10 years, 20 years, we go to the doctor once and they say, do this, that, and that, and we often rebel. So that's one of the factors, and it costs money to go to the doctor as well. So these are factors that lead to us decreasing our chances of getting screening, increasing our chance of dying. And I always point out to brothers that although we hate the healthcare system, we are not punishing the healthcare system by not going, because there is no reward with death. Actually, the devil wins when a man or a Black king is sick, because often a Black man covers a woman, covers 1 to 2 children, covers relatives. So the devil or the system gets a lot of bang for his buck when a Black man becomes sick and or dies. Next slide. What are the risk factors for colon cancer? Very, very important topic here, because it's less about genetics, which is the last thing. Family history does contribute, but the vast majority of my patients and in American healthcare are the first person in their family to get colon cancer. The leading cause of colon cancer is the environment. Our air quality is very poor. It's getting worse. One day we'll all be on electric cars, but until then, first world countries lead the world in colon cancer, and first world countries like our country with bad eating habits have a very, very high rate of colon cancer. So what should your diet be? Well, in a perfect situation, you'd be a vegetarian. You'd eat fruits and vegetables, period. Meats are inflammatory, and it's the inflammation, the drugs, the toxins that are in the foods you eat that end up mutating or causing cells that have cancer cells and point mutations in them to mutate, and that's how your polyps become cancer. Red meat being the highest inflammatory food. So if you ever had a vegetarian that has not had any meat for years and you accidentally feed them meat if you've seen that, they become deathly ill like they have the flu because their immune system is revved up and it's got to fight a battle that it's just not in shape to eat. People that eat hamburgers and stuff all the time, they eat red meat, they don't really get sick because their immune system is in there fighting day to day, fighting these meats. But meats are inflammatory, red meat, chicken, and then fish certainly is your least inflammatory meat of choice. My third point on this slide is pretty much significant in that age is a risk factor, but now we're seeing the younger you are, the riskier it is. Chadwick Boseman, the Black Panther, as many of you know, he was in his 30s when he was diagnosed. He had pain, so you have a 50% chance of beating it. His chance landed on tails, and in 5 years he had passed away. He did most of those movies with stage 3 and stage 4 colon cancer. He's an amazing man and actor. When he did the Black Panther here, he knew he had colon cancer, but he was in his 30s when he was diagnosed. He was a vegetarian. He was in much better shape than I was, and most of us were. Very unlucky, but colon cancer is on the rise for people born in the 90s, and it's a twofold increase in comparison to older folks that were born in the 50s, mainly related to air quality. For old people, it's because they live near a factory or they worked in a mine. For us, it's just because we breathe this bad air all the time for 20, 30 years and get colon cancer. Next slide. What are signs of colon cancer? Very similar to prostate cancer. Early colon cancer causes 0 symptoms. I'm unable to look at a patient and know who has early colon cancer. I can tell people that if they have advanced disease, they don't look or feel well, but it's kind of too late then. So all cancers come from polyps. Early cancer is about a 1 or 2 inch little lesion that's kind of growing on the side of the colon. There are no nerve endings on the inside of the colon, so you don't feel it. You don't feel polyps. There are no symptoms. So when people say, I don't have cancer, I feel great, they're just strictly lying and hoping and praying that they don't have it. What are some symptoms? What do I see when people have it? I've been doing colon cancer screening now for 20 years. Abdominal pain is the most common symptom. They eat, and about an hour after eating, sometimes they get pain as the food is going through a lesion. Sometimes rectal bleeding. If the lesion is towards the bottom part of the colon, bleeds like a hemorrhoid. It's not amount of bleeding, so I will share that with you. If you see a lot of blood, it's usually not from colon cancer. That scares people. But colon cancer likes to bleed like little teaspoons off and on. A patient will come in and say, Doc, I've been noticing some blood off and on, and just here lately, it's 2 or 3 times a week. I need to get that checked out, and that's can be from a cancer down at the bottom part. Bowel habits can get diarrhea, constipation, can lose weight if the tumor is getting bigger. We do not like to wait for weight loss because that typically is going to be a stage 3 out of 4 or a stage 4 cancer, and stage 4 colon cancer has a 15% cure rate. So my last slide there, last point on this slide says distant disease. When you hear about somebody, hey, they have cancer spread to the liver, 15% chance of being alive in 5 years. That's a big deal if you're 60 years old and you have a 15% chance of being alive in 5 years. Local disease, if we find it right in the colon, 90% chance of being alive in 5 years. And all of us on this call, we have a 99 point something chance of being alive because something can happen. But we like those 90 plus odds if it has to do with cancer and diseases. Next slide. So colon cancer screening, what are our options? And these are my last 2 slides. Well, colonoscopy is the gold standard. It's the only test that can detect and remove polyps. When you do have screening, and this is very important for you to share with your friends and colleagues, it decreases your risk of colon cancer by 90% and your risk of death 99%. It's a very, very, very big bang for your buck when people talk about, I don't want to do the prep. I don't want to have anything stuck in my butt, doc. I don't want anesthesia. I say, listen, it's better to meet me in the outpatient office. If you meet me at the hospital, you're going to be pooping out of a bag for 3 months before you get reconnected. You're going to have to take the prep anyway. 1 in 20 men get colon cancer. there's no real excuse you can give me. And I often tell people the adversity and the fight you have with racism and discrimination is nothing in comparison when you need to drink liquids and take a bowel prep to keep strong and healthy for your family. You're a king and you need to be healthy. The next screening tool, stool DNA, is called Cologuard. It's a trade name. It's a pretty good test. It detects cancer at 92%. It misses 8% of cancers. Colonoscopy misses 1%. So that's why colonoscopy is the gold standard. But Cologuard is non-invasive. You just poop in a cup. If you come see me, I fill out your address. They ship it there. You FedEx it back and get the results. If it's positive, you get a colonoscopy. If it's negative, you repeat it every 3 years. But it's not a bad test. It scores a 92, which is an A. It's just not as good as a colonoscopy. So colonoscopy detects polyps, detects early cancer at a rate of 99%. The caveat and the problem we're having, which is why we're having this discussion, is that 60% of Americans with insurance that should be screened are not, or screened. That means 40% are not. African American numbers are lower, anywhere between 40% to 50% of African Americans are getting screened. And we already know well visits or the screening is the way to go. If you come in to us sick and it's from colon cancer, cure rates 50 to 60%. If you come in healthy, if you have colon cancer, cure rates 90% or better. Next slide. So 2 big points. When do we get screened? Well, screening starts at age 45. It's 10 years before your family member. So if you had a family member that was diagnosed at age 50, you should start at 40. If you have a family member started at 45, you start at 35. And screening is every 10 years if it's negative. And Cologuard is every 3 years if it's negative. That makes sense. So colonoscopy, a little bit longer screening interval. As long as you don't have any symptoms in between, it's every 10 years. Cologuard is every 3 years. If it's negative, if it's positive, certainly that triggers a colonoscopy. Next slide. So we went over the commandments: no smoking, control your weight, blood pressure and cholesterol, diabetes. These are all things that lower your risk for heart disease. We hit pretty hard on colonoscopy. I think you understand why I support getting a PSA. There are arguments for population screening to not get a PSA done because of how long it takes people to pass away from prostate cancer. But most of us know somebody that got prostate cancer and or died from it. Mammograms speak for themselves. The facts are not negotiable. 1 in 8 women get breast cancer. The pink ribbons everywhere. Women are getting screened at 80% rates. Women are more likely to die from colon cancer than breast cancer. Next slide. We talked about getting the flu vaccine. We talked about wearing your seatbelt, wearing condoms, limiting alcohol, managing stress is very, very important. Getting counseling when needed. Black men in particular, when we get stressed, we withdraw. So I will share that if your friends that if they're depressed, they're not going to be texting you back at the frequency that you're used to. That's a red flag. They're not going to want to come out at the frequency that they're used to. Men, especially black men, we go in the cave. And unfortunately, sometimes we go so far in the cave, we don't come back out. It's our brother's keepers. It's our job as brothers when we notice people in the cave. If we're healthy and well enough to do it, we need to go in the cave and bring them out. We save lives that way by helping with mental health and stress. And that's just the main thing there, is that you have to be willing to go in the cave. If you use the mantra, I'll wait till he reaches out for me. I text him a couple times. He didn't respond. That's on him. You're really not your brother's keeper. You have to be willing to go to the cave. You have to be willing to stop by your brother's house and or call and or reach out to their loved ones to get in touch with them. That is the stress management. When our brothers are stressed, we withdraw. When women are stressed, they talk, they chat, they get help. Their suicide rates are nowhere near our rates. Black men's suicide rates up 200-fold past 10 years. A lot of reasons for that: social media, phones. We get constantly reminded of what we're not doing. We see on social media what our friends have and what we're not doing. It pushes us deep in the cave. So I just spent some time on that because I talked about colon cancer, prostate cancer, but suicide is making a rise for African Americans. It hasn't made the top 10, but it was never, ever on the top 10 in the history of the United States. And suicide may make the top 10 for Black men in the next 2 years. So I just wanted to make that point. Next slide. So last slide. Hope you're all informed on common diseases, our enemies. I think I cannot, again, understate discrimination causes stress. It causes poverty. It causes decreased being able to go to the doctor, increased risk of not being able to eat well, increased risk of not living in good neighborhoods. All of these things contribute to bad outcomes. So when we say, hey, African Americans have a higher death rate from this, higher death rate from that, you can't say those things without saying that there's a reason, there's a system in place that causes those things, and it's discrimination and poverty from discrimination. Rich Black men do well. Rich Black men don't live as long as rich white men because discrimination still is involved, but rich Black men do live longer than poor Black men. So, and that has been studied. So I hope that overall you're motivated to continue your health journey. Some of you, if you hadn't gotten a colonoscopy, may get one. Your PSA, working on your health and your tempo at all times. And I appreciate your time. Next slide. So I wanted to thank all of you for your time and attention. I kind of hit you kind of hard, but I come to you as in a loving spot, as a brother and all part of a village. But the stronger you are, the more better you are to take care of your family as a king. Thank you.
All righty. Thank you so much, Dr. Cross. Folks, we've had a wealth of information put out there tonight. I mean, a wealth of information from Dr. Cross. But we're going to continue the conversation now. We want to talk a little bit more about colon cancer as it is now. And he mentioned a word that we've talked about so much on these webinars, and that's disparities. I think one thing that we want to talk about is talk about disparities. What are the disparities between Black women and Black men in accessing the healthcare system? Because we know that Black guys are going to say, I ain't going to no doctor, whereas Black women, as soon as they come out of high school or whatever, they're going to go. So anybody can take this question, what are the disparities that we see between Black women and Black men, particularly when it comes to colon cancer? And of course, women don't have prostate, but they take care of themselves better when they do their mammograms and things than we as Black men do in our PSAs and things like that. So anybody can take that question. I'm just throwing it out there.
Yeah. Well,
Isabell.
Yeah, let Dr. Isabell touch on that.
Okay, so regarding a primary care in the office, this disparity, females, women, they're more open to going for their colonoscopy screening, where I see more per se men or Black men, they're very hesitant. They say, I feel fine. Some say if it's not broken, don't fix it. So try to convince them to get the screening, and unfortunately sometimes there's a delay in where the cancer, if they have cancer, until they get symptoms. A lot of times you don't have any symptoms at all. So that's the myth of I'm healthy if I don't have any symptoms, but then they start getting some symptoms, they may lose weight, or they notice blood, or they just appetite has changed, then they may consider to go. Some patients, Black, they ask, well, have you had a colonoscopy? I told them yes. And I explained it. It's pretty much, the prep. You're a friend with the toilet. That's your best friend. I use the word like you're once you bow, like you're peeing through your rectum but you have to keep yourself well hydrated so you don't get dehydrated, because it can throw your electrolytes off. Like if you have multiple other medical problems, like diabetes, hypertension. So one thing medical wise, you have to be careful and take care of yourself. I also do, HIV primary care, and also if colon cancers and any immune compromised illness is more aggressive. But another example, I had 4 brothers. It's hard to tell them that some of them haven't gone to a colonoscopy. My father, he didn't go until he was 70. After I got my colonoscopy, then he decided to go. They found, on the right side of colon, a large mass. We thought it was cancerous. He had to have surgery. It was so large they had to remove it. But it took years to go, even though we're involved in the healthcare to present to get your own family, a Black African man to go. It's not always easy, but it can save your life, because unfortunately, if it gets to the liver, the percentage goes down. So if you wait, because colon cancer, if it's diagnosed early, it can be curable. It's when it gets to stage 4, 3, or it goes to the liver where the prognosis is just very poor. Thank you.
Dr. Boykin, your point for women, life is often based on relationships, and for women, they have that GYN, and then they have a baby, that OB relationship. That is a very good relationship often, and then they just get that recommendation, go get a colonoscopy. It's like their sister telling them to go get it. They go get it. And men, especially Black men, just don't often have that relationship. And I often ask my patients, your relationship with your primary care doctor, do you rate it as average or great? And you'd be shocked how many times the patients rate their relationship with their primary care doctor as average, when it should be great. You're paying them. You should want a great relationship with your primary care doctor. And if it's not great, work on getting it, because people that have great relationship with their primary care doctor have better outcomes.
So, Dr. For you primary care, let's talk about your take on that, particularly from the aspect that most guys say, I don't trust the system. I don't know what you're telling me is right. Should I believe you? I don't want to be a guinea pig. That's one word I heard all the time. I don't want to be a guinea pig. So what's your take on that, Dr. Ford?
Yeah, but I think what Dr. Cross said is the relationship that you have with your patients. A lot of patients even come back to their primary care and say, even when they go to the specialist, and say, Doc, what do you think? If they trust you. Right. So that's about talking to them, building relationships. And that's when you can advise them what they should do. And a lot of times they will. But we know a lot of men, we don't come to the doctors unless we see blood or we're in pain. Right. That's the time that we want to run to the doctors. But we have to encourage everybody to come to their primary care or their other physicians, for the screenings. Because that's when we're going to catch something early, right? So that's definitely so important to stress that you have to go to your primary care doctor early on for your screenings. The other thing is, as men, we need to make our circle of men accountable, right? Everybody has 2 or 3 people, family members that, hey, did you get your colonoscopy? Did you get your prostate blood test? Are you checking your blood pressure? So you want to make sure that you're talking, because sometimes when we get in our groups, we may talk about the game. We're going to talk about other things, but sometimes we have to bring up the fact that, hey, how's your health, man? Did you go get your colonoscopy yet? And then when we put that peer pressure on people, that's when they respond. So as far as even in our frat, the chapters, right? We know that, hey, if you look at each chapter, there's this disease going on just like it is, in your patients. But we have to keep bros accountable too, right? So, you know, as men, we just need to make sure everybody's accountable. And also, what's important is to talk about your family history. You know, what came up not only in prostate cancer, colon cancer, and all other diseases. We have to talk to our family, because if we don't talk to our family, we don't know that someone had colon cancer. We won't know that we should be screened earlier, right? So I think that's so important.
So what about the folks that say, well, okay, all right, I know I need to get screened. I know I need to do this, but, you know, as Dr. Cross mentioned in his presentation, I don't want to have that thing put up my butt. You know, how do you convince somebody that, you know, if they're the right age group, particularly those ones in the younger age group, and they're high risk, to go ahead and get the colonoscopy, and they just want to opt for, man, just give me the poop in the cup test, and I'll be done with it. Let's talk about that a little bit.
The main thing that in my 20 years that has worked on people, one, since Cologuard is coming out, pooping in the cup, it's hard for someone to make an excuse that they can't do the screening by doing the stool sample. So number one, but the main thing is you have to speak people's currency, and their currency is usually what they love. It's rare that you find a person that just loves themselves and cares about nothing else. So it's often a goal. If they have a child, you know, you need to live another 10 years to see them finish high school, see them finish college, get people to kind of forward think. And what colon cancer does, it ends your life in 5 years. So once you get people projecting out 10 years more, those things are not, there's a 1 in 20 chance that doesn't happen for you if you don't get screened. And typically it's the family member. There are a lot of men that aren't afraid of them dying individually. It's more so what happens when they're gone to the people that depend on them. That often softens their stance, and they do that. I've seen women tell husbands, hey, listen, if you love me, you'll get it done. And that's the only reason they do it, because they do love X, Y, and Z. They want to see their granddaughter get married or whatever. You know, hey, if she hasn't met a man, then her chances of getting married is still 2 or 3 years out, and you need to get a colonoscopy. So it's mainly forward thinking. And then once people are living past today and they're thinking 5 years out, colon cancer kills you in 5 years. That's the main thing that often works.
So is there any reason or any type of person that should not get a non-colonoscopy screening test? Are there any individuals out there what should rely mostly on the colonoscopy and not on the Cologuard per se? Any people out there that need to know the difference between when to get the colonoscopy and when to get the Cologuard and when not to get the Cologuard?
Great question. So high-risk people, you have a history of polyps, you have multiple family members, or one is enough, but you have 2 or 3 family members that have had colon cancer. You've had precancer polyps yourself. You're having symptoms. These are high-risk things for colon cancer. Cologuard is not the test for you. Cologuard is a test for low risk and for screening. I feel good. I have no symptoms. I don't think I have anything going on. Let me get checked out. But if you're high risk, you want to get the test that doesn't miss because you're high risk. So I say, why would you do something that may miss when you're high risk for it? So we wear seatbelts every day and we're low risk for getting in a car accident. But if we get in a car accident, it's more likely to be fatal if we don't have our seatbelt. So that's why we wear our seatbelts all the time, even though we're low risk. But if we get into an accident, we're more likely to die if we don't get it. So if you have colon cancer, you're more likely to die if you wait for symptoms. And right now, the person in front of me has no symptoms. Now is the time to get screened. Now is not too late. If you meet me with weight loss and 10 pounds and asking for miracles, the only person that does miracles is the man upstairs, right? I can only help you with my physical hands. And I say, hey, God probably made you make the appointment, but now you got to do your part and follow through.
So how do we encourage? Go ahead, Dr. Isabell. I'm sorry.
To add to the Cologuard, like Dr. Cross said, it misses like about 8% of false negative, but then there's a high percentage of false positive too. And I've seen often some patients believe, oh, I have cancer. You need the gold standard colonoscopy because it also affects a mental issue when patient get the color guard because they're thinking the worst. So that's another thing you have to, I tell them that there's a chance that you could get a positive, but you have to get the colonoscopy, which is the gold standard. But there's a mental point. When anybody hears about cancer, they think automatically they have cancer. That's the problem. Color guard also.
Right. So how do we tell our younger brothers in our organizations, our brothers, Dr. Cross talked about, colonoscopy starting out at 45. How do we convince our younger, brothers and family members, for that matter, that they need to start screening for colon cancer, even if they don't have a family history? Because you said people in the 90s are at higher risk for developing colon cancer because our environment has changed from those people that are born in the 50s. So how do we convince these young people that, you really need to think about, first of all, you should go see your primary care physician on a regular basis. And B, you need to think about these things to be screened for. So what are some pointers? What are some tips for, one of our brothers in the chat said, this is a conversation we need to have all the time. What can we include in that conversation? Get these younger brothers that think they're invincible, that they need to get screened.
The main talk that I have with people is, I say, from 15 to 25, we talk to our young men about, we give them the talk, and when we talk about the talk, it's mainly about meeting with law enforcement. Often you brothers will talk to other brothers about de-escalation with other brothers. A lot of people have guns and stuff because homicide and car accidents and drug overdose are the #1 causes of death from 15 to 25. But once you cross into the 25 and 30, your #1 cause of death is starting to creep into cancer. So we need to have the cancer talk 30 and up. And so that's what's lacking in our community right now. We do a very, very good job talking about white man discrimination, white cops shooting us, black cops that, homies shooting us, getting robbed, stealing. We have that conversation weekly with young, and I'm the father of 3 boys. So, we have that conversation, and my son had his first traffic stop and it went fine. But that's a lot of anxiety. But what happens is you have to have the cancer talk and be persistent with the cancer talk. As Dr. Ford said, we have to be persistent and diligent with the cancer talk 35 and up, and peer pressure. You go play golf, you hang out, you say, hey, man, listen, I'm going to start rocking with you until you get that test because, I need you around. And the fact you're being irresponsible and you're not the person who I thought you were, because if you're not taking care of yourself like that, and this is a test, I'm not quite sure I need to be rocking with you right now. And typically your friends and my buddies, they go get the test done. They get tired of hearing my mouth, but I just include you for my golf outing or whatever. You're not getting invited until you get checked out if it's your blood pressure, because listen, I'm not trying to go visit you in the hospital with this stroke that's preventable.
That's right.
Right. So it's having to talk from discrimination, fighting, shooting and stuff, maintaining that same level of intensity, 35 and up, but switching it to cancer, health, and blood pressure.
So you're preparing them. You're preparing them because every time they come in, hey, at 45 is colon cancer. We're going to start getting your PSA at 40. We're going to make sure we get your blood pressure. So they know the routine every single time that they come in, that, okay, I know doc already told me next year is my year. They already had that anticipation of knowing what you're going to tell them, right? So I agree 100% with Dr. Cross says. We got to start preparing them early that this is what you're going to have and when we move forward.
100%. Routine physical exams, you bring it up. Also, a lot of churches now, they have like with Hope Ministry where you do 5 minutes, you may mention certain topics. For example, my church this month, we briefly talk about colon cancer screening, and those repetitive, and you touch 1 or 2 people to change their mind, and hopefully it can save a life.
Mm-hmm.
Wow. Well, brothers, this is, as always, we have a lot more we can talk about, but the time has run out on us. So I want to just take this opportunity to thank Dr. Cross for coming on tonight, giving us a wealth of information. And I'd like to take these last few minutes, if each of you would take about 30 seconds, just give a brief take-home point for our people, and then we're going to get on out of here. So I'll go ahead and start with you, Dr. Ford.
Yes. I'd like to thank Dr. Cross, also a wealth of information. I think it's so important, as I mentioned before, to make sure that you're talking to your family, to make sure you know their history, to also make sure that you're visiting your primary care doctor so that they can get you the proper screenings at the right time. Thank you.
Thank you. Dr. Isabell?
Regarding
Dr. Isabell?
colon cancer, regarding colon cancer
we hear you.
screening, risk factors: if you smoke, if you drink, if you have diabetes, if you obesity, high meat diet, processed foods, lack of good vegetables and fruit in your diet, all that can increase your chance of colon cancer. Know your family history, see your doctor routinely. Just don't only think about yourself, because if there's a delay, you can take years off your life. You may not see your child grow up. You may not see your grandkids. You may not see someone graduate from college. So you're thinking as insurance, you're trying to save your life by getting a detection to decrease your chances of getting stage 4. Thank you.
Dr. Cross, you got about 30 seconds, and then we need to take it on out.
Yeah, just
Come on. Yeah, there you go.
okay. Just piggybacking on what the doctor said, knowing the family, but opening your mouth, being your brother's keeper, being around for the loved ones that need you. You are someone of importance, knowing the king status that you are, that you need to be healthy, going to the doctor, doing the well visits. That's the main thing. Doing well visits when you're healthy and going seeing people, because when you get sick, the whole family gets sick. And that's what we have to understand, that once you are no longer well, you cannot earn money. And many of us are not independently wealthy. We need to be healthy so we continue to be wealthy or can earn money. And projecting out 5 to 10 years is what's needed. And thank you for your time, everyone.
All right. Thank you so much. And folks, this concludes our webinar for tonight. We want to thank all of our brothers who spoke tonight, and particularly our guest, Dr. Cross, tonight, for his wealth of information. We also like to thank our district representative, Brother Del Rico Gales, for allowing us to have this platform. And of course, last but not least, we'd like to thank Brother Peterson because without him, we wouldn't have this platform to do this. So pay attention to what the brother said tonight. Get your screenings done. Don't be afraid to go and see your primary care and discuss what's wrong with you. And by all means, please donate blood. Until next time, be safe and have a happy Holy Week and season.